Hello, and welcome to HeartSense's Fireside Chat series. Today, we will be discussing health policy and the effects on the LGBTQ plus community, and also the risk of cardiovascular disease within the LGBTQ plus community. This is featuring our co-founder, Dr. Antoine Keller, and our special guest for today, Dr. Dhruv Kazi, Associate Director at the Smith Center for Outcomes Research in Cardiology at Beth Israel Deaconess Medical Center and Associate Professor at Harvard Medical School. Dr. Keller and Dr. Kazi, welcome, and thank you so much for joining me today.
Hello, Sabrina.
Great. Okay, so Dr. Kazi, why don't we just start out with you telling us more about your expertise, because I'm really looking forward to this chat.
Thank you. I'm an adult cardiologist and care for patients with advanced cardiovascular disease, particularly those who are critically ill. My own research focuses on health economics and health disparities. So understanding not just how we increase access to new therapies, but also how we can pay for them and how we can advance access equitably so that patients at greatest risk can obtain them.
Great. Dr. Keller, would you like to add anything about how you know Dr. Kazi?
Yeah, Dr. Kazi was referred to me by a mutual friend of ours named Kim Gibbon, and we thank Kim very much for putting us together because I have learned so much from Dr. Kazi in the short time that I've known him. I can't wait to hear him expound upon this topic because it is a topic that's very important now for a number of reasons, and certainly important to people in general, not just people in the LGBTQ community, because we all have to interact with people of varying persuasions every day. And it's important to know what's going through their minds too. So I really appreciate him being here and I can't wait to get started.
So on the topic of heart disease, how does heart disease relate to the LGBTQ plus community? And what can we do about their risk for heart disease? Dr. Kazi.
Yeah, thank you for having me. I want to say that it gives me great pleasure to be here during Pride Month and to talk about this important topic. When we typically think about health risks for LGBTQ community members, we tend to think about mental health and sexually transmitted infections like HIV. And what I'd like to impress on the audience is that the number one health risk for all of us, including members of the LGBTQ community, is cardiovascular disease. So understanding an individual's cardiovascular risk and getting timely treatment and prevention is really important. I want to start out with making a few points. I'm going to talk in general terms, talking about this community, but all of us know that this community is not a homogeneous community of identical individuals. There are very different issues that affect a cisgender white man who lives in San Francisco compared with a transgender Black woman who lives in the South. And so although we talk in averages, as the listener thinks about these issues, I'd encourage them to think about individuals and realize that some of these issues may be more relevant to some families than others. There are also real geographic differences, which is, as I pointed out earlier, not just at the state level, but even within states. Urban communities where there may be less stigma and greater acceptance, there may be fewer barriers to care and less discrimination than we might find in other communities where prejudice is rampant. And the last thing I'd say is that there's a lot of intersectionality in the sense that we talk about stigma related to sexual orientation or gender identity, but again, it overlaps with other issues in our society, such as poverty. We know that individuals who belong to the LGBT community, particularly LGBT parents and persons of color, are more likely to be poor than heterosexual members of the community. And this compounds risk. And as we think about solutions, we don't want to just think about solutions along one axis. We have to find multi-stakeholder solutions here. So with that kind of exhaustive introduction, I'll talk about heart disease a little bit. Those of us who work on this topic have known for a while that heart disease is likely to be more severe and appear earlier in individuals of the LGBT community. However, the research on this is more limited, so I'm going to talk in broad, general terms. Why do you think individuals in this community are at increased risk? I think of it as 3 reasons. The first is what we think of as traditional risk factors: diabetes, blood pressure, cholesterol, exercise, obesity. Many of these factors are have greater prevalence in the LGBT community. So, for instance, tobacco use we know is higher in the LGBT community, and that's not accidental. Some of that may be the result of targeted advertising at this community. We know that sexual minority women have high rates of obesity and diabetes compared with heterosexual women. And then specifically when it comes to bisexual men, there is an increased risk of blood pressure, higher rates of blood pressure. So now you put all of these together and you clearly see a pattern emerging that the traditional risk factors that all doctors are used to considering when they think about cardiovascular risk, they're elevated in this community. Then there is the piece that is what I think of as non-traditional risk factors and that are specific to this community. Biggest among them is stress. And this stress can be the result of a variety of factors, including discrimination, social stress, poverty, internalized stigma. All of these factors can roll into a lifetime of stress that we know is associated with increased cardiovascular risk. Other things that are common: high alcohol use is common in some subgroups of the community. And then I want to specifically talk about HIV, which is a major consideration for the health of men who have sex with men. So both gay men and bisexual men are affected. HIV, as it is treated today, is less of a risk factor for heart disease because we catch it early, we treat it early, and the medications are very safe. But back in the day when we were delaying treatment for HIV and we were using these drugs that had a lot of side effects, particularly related to their cholesterol. So men who are older today, maybe in their 60s, living with HIV, have been exposed to these medications, and those individuals may have higher lifetime risk of cardiovascular disease. And then I'll close with this thought that, great, so there are these increased traditional and non-traditional risk factors, but then once individuals develop cardiovascular disease, they come up against health systems and health policies that don't always work in their favor. So until marriage equality was passed, members of the LGBT community had lower rates of insurance. That is still true, particularly in the states in the South that have not expanded Medicaid. Again, like I mentioned, they're more likely to be poor and therefore more likely to benefit from Medicaid expansion. There's discrimination, whether we like it or not. We have to be transparent that our health system has its own problems. And then I talked about the stigma. If you don't, either because of your physician's behavior or because of your own self-consciousness, if you don't trust your physician with your health information, that affects the physician's ability to diagnose and treat heart disease. So this constellation of factors is the reason why individuals in the community are at higher risk of heart disease.
So I would like to ask you, Kazi, about LGBTQ physicians and communities in which there are physicians that culturally or socially identify with the LGBT community, and what impact that might have on people who have cardiovascular disease getting the appropriate treatment that they need. Not just cardiovascular disease, but in general, in terms of wellness and living a healthy lifestyle as a gay or lesbian person. How does having access to LGBTQ physicians actually improve care or improve the likelihood that these people will get the appropriate treatment for their problem, even hypertension?
Yeah, I mean, we've data, that's a great question. We have data now going back many years showing that the trust with the physician and with the health system more broadly correlates tightly with the patient seeking care, continuing to stay in care, take their medications as prescribed, provide information to their physician. And that's not just across sexual and gender minorities. That could be by race, ethnicity, it could be by culture. if we believe that our physicians and clinicians more broadly understand us and respect us for who we are, we're more likely to be transparent with them and take our medications as prescribed. Now, as you can imagine, for the LGBTQ community, this manifests in a few different ways. One, of course, is just participating in healthcare at all. So if you don't actually have a primary care physician that you trust or that you see regularly, you're not likely to seek care for that chest pain that you've developed or the fact that you're exercising less. All of this is going to go unnoticed for a while. And so there's delayed diagnosis associated with not being in care or not being seen by a physician you trust. There are the other part to this, and again, going back to the HIV question, particularly in the South, we have an issue that men who have sex with men are not as likely to be on pre-exposure prophylaxis for HIV. And part of this is stigma. Part of that is the trust in the healthcare system. And so I would say particularly for gay and bisexual men who are sexually active, getting on PrEP and making sure that they reduce their risk for HIV is in my books part of cardiovascular prevention, because once you get HIV, you're at higher risk for cardiovascular disease. But in more generally, trust is a key ingredient to successful medical therapy. We know that there are a very few LGBT identifying physicians in this country. On last count, fewer than 1% of physicians. Many medical schools are now making active efforts to rectify that. But in the meantime, though, I think I would like members of the LGBT community know that that most physicians are trustworthy, that they are more than happy. We all have either are members of the community or have family members who are in the community. And so the time when there was an automatic prejudice against members of this community are now slowly fading away. I think transgender individuals still have real discrimination in the health system, and that is our fault. We need to fix that, each and every one of us.
Yeah, and Sabrina and I learned the other day, and it was interesting to me that there are physicians who have bios and email signatures. If they list their pronouns, then that might be an indication to people in the LGBTQ community that these physicians are accepting and understanding of LGBTQ people as patients. And I thought that was a little thing, but I think it's something that is significant for sure.
Yeah, I think that's a really good one. I mean, I think most health systems that are inclusive are now insisting that their clinicians list their pronouns, that that we ask our patients about their preferred pronouns, and all of this can go a long way to building that platform of trust.
So this is really interesting because everyone, is so different, just like any individual in the world, but specifically for the LGBTQ community, if you are a patient of this community, how can you manage your cardiovascular disease risks? Or is that something you can actually identify?
Absolutely. I would say that each one of us should think about what our individual risk factors are and what we can do about them. So there are some risk factors more broadly that affect all of us. We should be eating a healthy diet, getting good sleep, getting adequate exercise, trying to manage as best our weight into a healthy weight. A big one for the LGBT community, I would say, is that if you smoke or have exposure to secondhand smoke, cigarette smoke, use the resources available in the community, both through the health system, but more generally in the community, to try and quit tobacco. Quitting tobacco is hard. It's particularly hard when other members of the community smoke, when there's targeted advertising bombarding us all the time. And I think, but so rather than just saying, I can't quit, I've tried before and it doesn't work, rely on your clinicians to provide both pharmacological resources, but even support that you need as you quit. Second, so that's broadly just making healthy lifestyle changes so that you can get the traditional risk factors under control. A big one here would be blood pressure. So if you haven't had your blood pressure measured in a while, this is a good time for us. It's Pride Month. Maybe it should be Pride Heart Disease Month. Let's get your cholesterol checked, get your blood pressure checked, see if your blood pressure is in the normal range. And then if it's not, then do something about it. Just knowing that you have high blood pressure doesn't solve the problem. I think the non-traditional risk factors, we have increasing recognition about mental health being tightly linked to heart health. And hopefully we are moving to a space where, particularly with the pandemic, which has been so hard on all of us, to accepting that mental health is something that requires work, it requires investments. All of us at some point in our lives will grapple with depression or depression-like symptoms. And I'd say it's important to recognize when you're in that state and get help, not just from friends and family, but professional help if needed. And I come from the school of thought that says if we take care of our mental health, we dramatically improve our cardiovascular outcomes. So
yeah, people don't realize how much stress mitigation impacts cardiovascular risk factors, because all of the things that happen to you when you're stressed, people overeat, people smoke, people lead sedentary lifestyles, all of these things increase your risk of heart disease. But a lot of them can be referenced back to stress and your coping mechanisms for that stress.
Yeah, in fact, if you look at the literature on why LGBTQ adults have increased risk of heart disease, the underlying principle is that it's probably stress related. Social stress, economic stress, that then manifests itself in different ways: higher blood pressure, higher cholesterol, poor lifestyle choices.
It's really interesting. So tell us, if you could, about what kinds of things people who are in the LGBT community can do to ensure that they have the right access to cardiovascular care. Are there things that they can do? Certainly would be different from one region to the next, but can you expound a little bit about the kinds of legal ramifications that not having access to care, or having access to care and in a place like in the South, for instance, when common law marriage or civil unions are not a way in which we identify people who are actually married. And can you expound upon those issues and how people who are in the LGBT community should kind of try to circumvent social norms or political norms in the particular region like the South, how they can get around those things? When we were talking, setting up this fireside chat, you mentioned the fact that if people in certain situations in states in which they live are not considered married, then end of life decisions become a challenge sometimes, because the person who's married to the person in the LGBT community might not be able to make choices that that person would want to make. It might fall to someone else in the family that is not necessarily married to the person. So this is kind of a really interesting topic that is specific to regional variations, but I think it's important for people to know that they need to think about these things in advance if they do live in a place that is relatively intolerant of civil unions.
Yeah, this is a really important question because it directly affects the lives of people living with heart disease. I would say start with understanding your, as would anybody, understand your health insurance, understand your access to care. If you don't have health insurance, examine the resources that are available to you under state law. Do you qualify for Medicaid? Do you qualify for support, subsidies, etc., so that you can get insurance? Individuals from the LGBT community are still at higher risk of lacking insurance all things considered. And I would love for us to be able to change that, because health insurance is the gateway to good care in the US, whether we like it or not. The second is find a trusting primary care doctor, someone that you know will hear you, who you can trust with information, personal information. And I can, in some areas of the country that might be hard. In some areas of the country, it might be straightforward, but it's best to find a primary care doctor when you're healthy, because that's a relationship you want already operational when illness strikes and you need someone by your side to guide you with the health system. And so I would say if you've had previous experiences that were negative, I apologize on behalf of the health system, but I'd love for you to try again and get healthcare. We need to advocate for ourselves and find ourselves a primary care provider we care about or who we trust. And then, going back to the point, Antoine, that you were making about decision-making and healthcare proxies. In, at least as of now, the law of the land says that if you're married to an individual, they have the right they are the default decision makers if you're not in a place to make those decisions. And it doesn't matter whether you're in a same-sex relationship or not. Civil unions and common law are a different story. And many states, including states in the South, have a tradition of common law that very well recognizes heterosexual relationships. And it would be important for, it's unclear how they play out for same-sex relationships. And so what I would say to members of the LGBTQ community who are in same-sex relationships but not married is to explicitly create the documentation of your healthcare proxy. Who is it that you want to make decisions for you? Because the law is pretty rigid that if it's not a spouse or a partner recognized by the law, it defaults to family members, even if the family members are estranged. And so particularly in a community where relationships with family can be estranged, it's important that the healthcare proxy be well documented. And it's the best thing to do for you yourself. It's the best to do for the family, but it also helps physicians and clinicians who deeply care for you do the right thing for you if you're not able to make decisions for yourself. So again, this is a thing where it takes no more than 5 minutes to fill out the form, and it can, you can make copies of it, stick it on the refrigerator, keep it on your phone, wherever your partner can find it. But those 5 minutes can save you and your partner so much grief when things, if things were to change suddenly. And it could happen to any of us. You could be completely healthy. We're not prepared for adverse life events. You're young and healthy. You get in a car crash and you're in trouble. So the time to make a healthcare proxy is now.
That is such a fantastic point, and I think one that needs to be emphasized, especially in this day and age when we really don't know how health policy is going to change. Seems to be changing almost every day going forward.
Yes, that's really interesting, that point you just made of the health proxy. I think I need to get myself in gear and get something together, put together some kind of list for my spouse to be aware of and vice versa. So thank you for that.
And of course, a healthcare proxy is just, as a quick digression, healthcare proxy is step one. We all need it, but it's also really helpful to have the conversation with the healthcare proxy as to what your priorities are. For if they were to make decisions for you. I've had they're tough conversations. They're particularly tough to have when you're healthy. You feel like you want to defer them, but the right time again to have them is when you're healthy. I recently had this conversation with my parents, and they've been married, gosh, I should know this, 53 years. And they both had very distinct end-of-life preferences. and I would have never known had I had not had a conversation with them. And so they don't have to be long, they don't have to be awkward. In fact, they're easier to have when we're healthy. But these are conversations that all of us should be having, but particularly if you're in the LGBT community, where the law does not clearly identify our healthcare proxy, it would be helpful to have these conversations early and to document them.
Absolutely. That's fantastic. So I have one follow-up question before we get to our rapid fire round of questions, because I would really like to get some questions from our LGBTQ community in front of you so you can expound upon them. But I wanted to ask you how you thought the telemedicine has impacted the ability of people in the LGBTQ plus community to be able to get cared for by physicians who are in the same community. And do you know of any telehealth constructs right now that can put LGBTQ people in touch with physicians or practitioners who are sensitive to their situation?
That's a great question. I mean, as possibly the only silver lining that came out of the pandemic has been the rapid adoption of telehealth in the United States. This is something we've talked about for over a decade. And yet there were always, well, we can't do this because of X and can't do this because of Y. And the pandemic rolled out in March of 2020. And by April, most states had very liberal telehealth laws to allow physicians to see their patients remotely. In fact, even across state boundaries, which have since been rescinded, but it was an interesting experiment while it lasted.
Yeah.
I think telehealth has many positive possibilities for the LGBTQ community, both as it relates to health overall, but specifically as it relates to cardiovascular health. In terms of overall health, as Antoine, you mentioned, there is the possibility of finding a physician that you trust and who you think is inclusive in their worldview, which again is highly predictive of whether people take their medication, stay on their medication, get the care they need. So it's really important that we do that. Interestingly, there is a number of services that are offering pre-exposure prophylaxis evaluations as part of a telehealth service, which is really important because it's a conversation that young men in particular may have trouble having with their primary care providers, and asking for a pre-exposure prophylaxis, because in effect it involves revealing both one's sexual identity but also one's sexual practices. And so these relatively anonymous telehealth services where you can get tested and get your PrEP prescriptions are I'm hopeful will help expand PrEP access in places where this has been a problem. Again, I think of PrEP as being on the continuum of cardiovascular care because it reduces our risk in the long term. I think in other settings, I am hopeful that this will help alleviate the rural-urban divide in cardiovascular health. And I know you've done a lot of work in this space, but the fact that, if you're living in rural America today, not only is your risk for heart disease higher, but your ability to get timely, high-quality care should you develop a heart attack or a stroke or heart failure, all of this is lower in rural areas. The high-quality care is lower in rural areas. And while some of this cannot be delivered by a telehealth mechanism, you can't have a telecath lab. You still need to be able to be at a hospital where if you were having a heart attack. But there is a lot of care that can be delivered remotely. And so not just for the LGBT community, but just more broadly, I'm hoping that the rapid uptake of telehealth will mean some reduction in rural-urban health disparities, particularly as they relate to heart disease.
Yeah, I think that's a great answer because it really has become part of our way of life now, telehealth. And We are always looking for people with innovative ways to be able to make access to care easier. And I think it's a place in which we will see a lot of growth over the next several years, for sure.
One of the areas that I should also mention is growing is cardiac rehabilitation. So people who live with heart disease, advanced heart disease, maybe they've had surgery, they've had a heart attack, they're living with heart failure. And again, cardiac rehab has traditionally been, you go into a center 3 times a week for 12 weeks. And now there are a whole bunch of programs that are trying to help these patients at home. And I'm hopeful that access to cardiac rehab will mean that people will have better outcomes in the long run. Again, particularly in places where they didn't have access to centers in the first place. No one drives 100 miles to go to rehab. So if you're that far from a rehab center, you're not getting it.
Right. They're not getting their access to their care. And so that really hits home with what HeartSense is doing for identifying that undiagnosed cardiovascular disease in communities, that don't even really have doctors in that area. So yes, we hope that for the future, something like that would be able to happen in a lot of those other communities around the country.
Yeah,
yes.
Absolutely.
Okay. Well, this has been such an eye-opening, enlightening conversation to learn about cardiovascular disease and risk within the LGBTQ plus community and also with health policy. So we do have some questions from the community, and this is going to be more of like a rapid fire question and answer. So Dr. Kazi, are you ready?
Totally.
Okay.
Good. So I have a number of friends in New Orleans who are very interested in these issues, and they have asked me to ask you a number of questions, a lot of which you've already covered actually in your very fine fireside chat, but there are a couple that remain, and I would like to shoot them by you if you don't mind. First, is giving blood, if giving blood is such an important thing right now because we have national shortages of all kinds of blood products, gay men are still not allowed to give blood, even though they have tested negative and they test the blood that comes into the blood bank for all of these viral diseases and bacterial syndromes as well. Could that be something that is changed in the future? Does it take having a critical blood shortage to be able to allow gay men to give blood, or do you foresee some change on the horizon that might make that something that would be a reality?
Yeah, this has been a tough and a controversial issue for a very long time. And as you know, the ban on men who have sex with men donating blood has changed over time. So originally it was indefinite, then it was 12 months, and now during the pandemic it was reduced to 3 months. So men who've had sex with men, another male partner within the past 3 months cannot donate blood. The current conviction is that the FDA will keep this 3 month, the shorter deferral period even after the pandemic resolves. I think that as stated, and as many of your friends have pointed out, this ban or deferral, as they like to call it, is problematic because it whether we like it or not, it anchors in homophobia that somehow this blood is contaminated without actually considering the risk involved. I think that I'd say 2 things. The UK does it better. In that their deferral program says if you've had anal sex with a partner who is not your usual partner, then you cannot donate blood for a period of time. And I think that makes sense because the risk isn't whether it's a man to man or man to woman, it's the activity of anal penetrative sex that is the high risk activity. And the other piece is that as we normalize gay relationships, straight same-sex relationships, we find lots of people in monogamous same-sex relationships. And in that case, their risk of HIV is no different from someone in a opposite sex monogamous relationship. So I think, again, focusing on whether you've had one partner or more than one partner is probably more directly related to risk than this idea that, men who have had sex with men in the past 3 months should not donate blood. So do I think that this policy needs to change? Absolutely. Are there studies ongoing? Yes. Do I think that it will change in the future? I am very hopeful, but it might be slow.
A while, huh? Yeah.
We're heading in the right direction, but progress has been slow.
Yeah, as kind of an aside, do you know if the same restrictions apply to solid organ transplant?
I actually don't know that. I should look.
Yeah, that's an interesting question.
It's related to HIV transmission, so that's a really good question.
That just occurred to me. Okay, well, that's a great answer. So the last question has to do with healthcare policy, which is one of your areas of interest, and specifically with Roe v. Wade and the potential repeal of Roe v. Wade or overturning of Roe v. Wade as the precedent. And if you think that will impact other healthcare policies going forward, not necessarily related to Roe v. Wade specifically, but related to the possibility that something that has been the law of the land for 50 years, I believe, could potentially be redirected in another way. And could that affect other policies that we have in place right now that might impact LGBTQ community people?
Yeah, I mean, I think this is a particularly tough and depressing time when it comes to health policy because of the precedent that the repeal of Roe v. Wade would set. So if the argument is that abortion rights are not deeply entrenched in the Constitution and therefore must be deferred to states, then the same argument can be made for marriage equality. And there is concern that these rights that have only existed for a decade or so, but have started to take for granted, may disappear from under our feet. What does that mean for healthcare? There are at least two important implications. The first is, and I mentioned this earlier, that in the US, particularly in populations younger than 65, a lot of individuals get care through their spouses, get insurance through their spouses. And I'm in a civil union, or I'm married to a person who has insurance, and their plan will allow me to add myself on that plan. LGBT communities have been excluded from this privilege in the past, and this changed with with marriage equality and with some clauses in the Affordable Care Act, and you could see an increase in insurance coverage in the LGBT community, now almost about the same as that in individuals who identify as straight or heterosexual. That might change again. And so a lot of people would be at risk of losing insurance that they're getting through their spouse if marriage equality goes away. And then the second was what I discussed earlier, which is that as long as marriage equality is the law of the land, same-sex spouses have the right to make decisions for their partners when things go wrong, to serve as healthcare proxies. And that will disappear in many states. And so again, it will become even more important to have a healthcare proxy in place. What I would say to members of the community is that let's not take this right for granted. And let's again commit during Pride Month to designate a healthcare proxy. It doesn't matter how old you are, how healthy you are, what your family dynamics are, whether it's a friend or a family member, designate one person to be a healthcare proxy and have the conversation with them so that they understand what your priorities are. I'd love to close on a positive note. I mean, this is if we've learned anything in the past few decades, it is that this is a very resilient community. Been through the pandemic of HIV, been through decades of discrimination, advocated for the community in terms of marriage equality, other rights, employment rights. We have come a long way and have a long way to go. So, and there is a silver lining here. We know that individuals are now have more access to health insurance. We live in an environment where hopefully we have greater access to inclusive care providers and to medications, both for prevention and treatment. And our role in the community is to make sure that we use these resources to live happy, healthy lives. It's happened before, we can do it again. Happy Pride, everyone.
Yes.
You're fantastic. Kazi, I cannot thank you enough for coming and joining us on this chat. It's been so enlightening, and we really appreciate you sharing your wisdom with us.
Yes, thank you so much, Dr. Kazi. And we look forward to, hearing more in the future how this health policy is going to really affect everyone in this community and also everyone, in the States, and to really figure out more on research for the cardiovascular disease and risk in this community. So thank you so much for your time. And happy Pride to everyone out there in the community. And thank you so much for watching this fireside chat.